Hello and welcome to the Sage Oak Show, Senior Care Simplified. I would like to welcome my first guest today. He is Dr. Alex Anastase, board certified in physical medicine and rehabilitation. Dr. Anastase practices include inpatient rehab as well as hospital and skilled nursing in the Denton, Texas area. He is a good friend of Sage Oak, and we're so pleased to have him with us today.
Yeah, thank you so much for having me. I appreciate it.
Great.
It's exciting to be here.
Yeah, it is. It is fun. It is our first ever Sage Oak podcast. So very pleased to have you on board with us. So you are the current medical director for a few different places, right?
Yes, So I'm a medical director for Select Rehab Inpatient Hospital in Denton, as well as Denton Rehab and Nursing Skilled Nursing Facility and Senior Care Brinker Skilled Nursing Facility, and I go to another one, Vintage, as well up in Denton.
Awesome. You have plenty of experience then dealing with seniors and what they're trying to navigate right now at that stage in their life, and probably families as well, I would assume.
I hope so. I've been doing it for 10 years, but I enjoy being up there and just working with that population that, a lot of times, obviously, no one goes sees their doctor when they're feeling well. And so whenever I see patients, they're not doing well functionally or medically or whatever. So it's not a great time for the patients and the family members as well. But I like to try to do the best I can to fill that role of trying to be a helper, a transition, just a speaker to them to kind of see what the options are, and then just be a part of the community as well. That I enjoy being up in Denton. It's a good place to work, and it's a very thriving. There's a college there, UNT, aging population as well. That's a good city to be working in.
Well, Denton is very lucky to have you.
Thank you.
For sure. And I'm sure certain families are very open to coming to you. What we find at Sage Oak is when we do tours with families seem to be a bit confused on where to begin and kind of how they wound up sitting in front of us sometime.
Sure.
I'm sure that's something that you similarly find with them. What is one of the most common things that families come to you and ask?
That's a good question. I think I'll see if I can tie it into what we both do. But let's say somebody goes to the hospital, they either get sick, they have a fall, have a stroke, have something pretty catastrophic happen. They first go to the ER, and so in the ER, the physician will see them to see if they need to be admitted or not. A lot of times, they can be seen and sent back home, and then they can follow up as an outpatient. If you're then admitted, that's going to be what most hospitals, your Presbys, your Baylor, medical cities, all those are short-term acute care, so STACs. And so they go to the STAC, and this is a big question I see that. After the STAC, they're there, that's short term again, maybe 2 days, 3 days, 5 days, a week, 2. If they're really sick in ICU, they can get up to a month, but that's rare. Usually it's a bit shorter stay. And once they're stabilized, then what? And so hopefully most people can go home. And so if they can go home, then it'd be either with home health or outpatient therapy if they still need some mobility assistance. Or if they can't go home, then that's how they get to me. And so then your options post-discharge from an STAC are either an LTAC, long-term acute care hospital, an inpatient rehab hospital, and a skilled nursing facility. So I used to go to an LTAC, but it's been some time. But the 3 main criteria for that are either some kind of IV antibiotics, either infection of the bone, osteomyelitis, maybe of the spine, discitis. Oftentimes people have hardware, they have knee replacements, hip replacements, that unfortunately can get infected. And so if that infection gets in there deep, they're going to be on IV antibiotics for 6 weeks. Mm-hmm. And so then potentially they could go to an LTAC to finish that out. Oftentimes the second part is a wound. And so with these infections and just wounds or people not being able to move very well, they can get pressure wounds and just other wounds that if it's a significant wound burden that requires either debridement, maybe hyperbaric oxygen, wound vacs, those also qualify for LTACs. And the third category would be pulmonary. So if you have a ventilator and difficulty weaning off that, or maybe a tracheostomy associated with that too, you might have a feeding tube and a peg tube, and so then an LTAC might be the next appropriate spot. If someone was a little bit more stable, doesn't need as long a stay, or doesn't have the other criteria, then maybe they come to me, inpatient rehab or skilled nursing. So inpatient rehab is a little bit more medically acute. They have, we see critical illness, myopathies, neuropathies, just people that have been in the hospital for a long time, a lot of neuro cases, strokes, MS exacerbations, multiple sclerosis, Guillain-Barré, so things that affect function that they can't go home, and they just need physician oversight on a daily basis, as well as the daily therapies. And so, usually higher medical acuity. If patients are fairly stable or, need a little bit longer time, they don't have something as serious, either like a urinary tract infection, maybe pneumonia, a little bit older patients that they don't quite need that level of oversight but need more time, then skilled nursing might be the next step, and then they go there. And so after all that, hopefully we get our patients home, but if not, then that's where you guys come into play, that potentially then assisted living might be an option, or independent living facilities, or even nursing homes. And so, it's kind of a gamut across the spectrum of where these patients go, but it can be very complex, and obviously making these decisions in the moment when somebody's sick and their family's sick or loved one's sick, that it's hard. And so I see that they're kind of deer in the headlights, and they're like, what do I do now? And so they come to me, and I try to explain that the best I can. And, it's still, an ongoing daily, depending on the patient does. I mean, the options change.
Yeah, it certainly is a case-by-case situation. That's what we find a lot when we're sitting across the table from families, is that they have perhaps been through this very complex maze, like you've just described. There's so many options once you're in the hospital, where you go post-acute. Do you go to LTAC? Do you go to skilled nursing? Do you just go home? Maybe it's home health. So we try to help them move through those phases as well and kind of weigh out the options. A lot of our families also seem to get a little confused when it comes to choosing between, do we go to skilled nursing or is it assisted living? In Texas, the rules and regulations are a little in the gray area on some things that we can medically take. Sage Oak in particular makes it a point. We've built our business model so that we are able to take a little higher acuity than a lot of places because of the way we built our business model and our staffing ratios. We have the ability to have more of that one-on-one type care with the residents. So we like to try to fit somewhere in that space between traditional assisted living and what they are able to take and skilled nursing, to try to, if they're going to be in it long term, of course, so that they are able to have a different quality of life than perhaps maybe sharing a room with someone or being in such a clinical setting. Do you have any advice for families if they are weighing between those two options?
Yeah, so, we've talked about it, but, it's not just a patient issue. The patients aren't the only ones that are dealing with the illness and being sick and being in hospital and lack of mobility, but the families are as well. And so,
absolutely,
when they see me, they may not have a good day, week, month. You guys, it might be, they may not have several months that aren't good, or years that the mobility are just becoming a little bit harder to manage at home, that there may be incontinent issues or difficulties with ADLs, activities of daily living. And so what I would say between those two, skilled nursing and assisted living, the skilled nursing is still a little bit more acute. And so if somebody was doing fairly well before, still has a chance to getting back to independence, doing a little higher level in a sense, that maybe a skilled nursing in case they have that pneumonia or that UTI or whatever's going on, that they're in the hospital, can't go home directly, or even if they go to inpatient rehab, they just need about a month's worth. And then the goal is to go home and there's good family support and there's people there, then maybe skilled nursing might be the option. If it's more of a long-term kind of situation that they've been in the hospital a couple of times, they've gone through all this, they go home, they make it back, or just the family, it's tough here that people work and the distances that, I come from actually, Eastern Europe, Romania, and Europe, Asia, Africa. The culture's a little different, but there's also not these, these facilities. And so people go home with families. Here, the distances are so much further. Like there, you might have families within 10 miles, 20 miles, maybe 50 miles. Here, you're talking hundreds to thousands. And so it's tougher to have the support at home to be able to take care of somebody that needs that higher level. And so if it's more of a long-term situation, then that's where, Sage Oak or assisted living, maybe independent living if they're doing relatively well, but just need a little bit more supervision, some assistance with getting dressed in the morning, maybe medications, meals prepared. I've been very impressed with y'all's meals, by the way, at Sage Oak.
Thank you.
Food is fantastic.
They are fantastic.
Yeah.
We're very proud.
It's good. And so, yeah, if they just need somewhere to be more as a destination instead of a quick fix or a fix for the short term, that's where the assisted living might be a better option.
Yeah, I think that's really great advice. And we like to partner with the skilled nursing facilities as well, because there are times that they come and they do move in with us, but perhaps they come down with a pretty bad UTI or urinary tract infection. That's very common with the aging population. And sometimes if we catch it early enough, we can reach out to their primary care physician, get some things in place, and take care of them in-house so they can stay home. But there are times that it just kind of runs rampant before you can get a hold of it, and they do need to perhaps admit back to skilled nursing for a temporary stay to get that under control, maybe do some IV antibiotics to knock it out quickly. But that's why we like to partner, because we always want them to come back to us home, but sometimes there is that higher level that's needed intermittently as well. So since we mentioned urinary tract infections, I think that's a really good spot to take a minute to discuss, because that is such a common occurrence in a lot of our residents, as well as potential residents that we speak with families about coming in. They describe circumstances like their mom or dad just isn't acting like they always had. Sometimes they even think maybe it is dementia onset, but they've not experienced any other signs or symptoms, so they automatically jump to that. But sometimes it's not dementia, sometimes it is a temporary scenario. So can you talk about some of the common signs and symptoms that people can look for when they're home to recognize that earlier rather than later?
For sure, yeah. So what you're describing is a short-term change in mental function. Is called delirium. And so dementia and delirium, they can present similarly. But dementias are usually a little bit more insidious onset, kind of over time, over months, years. You notice a little bit, they might forget where they are or start losing things over time. Whereas the delirium is a much quicker onset, that somebody's doing pretty well and all of a sudden they're very confused. So in our older populations, it's the biggest thing I look as for as a physician is any symptoms. So any kind of burning with the urine, any kind of odor with the urine. Any changes with those functions, but that's often not the case. And so you're right that you can look at behavioral type things, and especially if there are some underlying cognitive, that then it gets to be either agitation, maybe hallucinations, confusion, combativeness. They're hitting out when they typically aren't, very mild manner, and then somebody changes a little bit in terms of how they react to either staff or family members. And so just any kind of change in behavior. Any somnolence, any sleepiness, just change in alertness. There can be fevers, there can be other signs too, but more just a mental status change is what we often see. And so, those are treatable, and obviously, if you do see those in your family members, I get evaluated fairly quickly in the emergency room, and a lot of times it can be treated and go back home and things clear up pretty quick. Sometimes it doesn't, and so that's where the other options of potentially discharge dispositions might be come in play.
Yeah. So we also find related to urinary tract infection onset, what some advice is that can try to deter that from occurring is hydration. Hydration is such an important part of keeping that infection away, as well as good incontinence care as well. But hydration is huge with our seniors. They don't seem to really want to drink as much water or fluids at all. I think a lot of times that is connected to, if they do have incontinence issues or urgency, it's harder for them to get to the bathroom. So they think that by not drinking enough water, they won't have to go to the restroom as often, but it really leads down a road that is harder to come back from for them. So do you have any advice on kind of tricky ways or creative ways that people can add hydration?
Yeah, it's I totally agree with you that you got to flush out the system. And so if you're not, then things, your urine's going to stay in your body a little bit longer. Also, mobility can be impaired. Getting to the bathroom gets a little bit tough. They don't want to bother anybody, and so just the hygiene is going to be key, especially if there's any incontinence. That all of that's tied together. But in terms of drinking enough water or getting more fluids, there are the packets, the Mio packets. I mean, if somebody doesn't like the flavor of water, which I understand, you can take a couple drops and it's still mostly water, but it changes the flavor a little bit, that it makes it a little bit more palatable.
I do that daily myself.
Yeah, me too. I like teas. I mean, just any way to get more fluids in. And so, sometimes it's easy fixes, or if there are cognitive deficits, then just encouraging or bringing somebody a cup of water, or, have even like a bottle of water with a straw there that's easy to reach, or maybe even prompting or cueing the family members to drink water throughout the day.
Yeah, we like to do that as well, especially with our residents that do have cognitive impairment. If you just set a glass of water in front of them and tell them, drink your water, for us, it's easy to think that's a simple request, but it's a lot harder for them to process that information. They may understand it in the moment, but in a few more seconds, that thought is gone. So just really being persistent, and every time you pass by them in the house or in the kitchen, just have that water available, or any beverage that they'll drink, really, and just reminding, here, take a sip. Just all of that helps so much, little by little. And you can also, other things that we've done, popsicles. Popsicles are a great source of hydration, and it's fun to eat, and they don't necessarily know that they're getting hydration.
Yeah, that's a good idea. And also the cups that have the little measuring, device on the side, so you can kind of see how much is being, drank throughout the day, and just keep track of that and just keep encouraging. And so, yeah, I'd recommend probably, if we go by liters, and so about 1.5 to 2 liters a day would be ideal. That's about maybe 50 ounces, 60 ounces in that ballpark. And so getting at least that would be ideal. Now, if somebody's already kind of limited on fluid intake, and then they're drinking coffee and sodas and whatever, then it also impedes their want to drink water. And so if somebody's already limited, I would try to recommend just as much as possible to make that water, especially if you do have the renal patients or the congestive heart failure, cardiac patients that are on fluid restrictions already, to try to make that fluid intake, if they're being restricted or they just don't do it, as much water as possible, with flavoring or with not. That helps tremendously over time.
Yeah, and that's advice that I think all of us can use, which is maybe we should drink water more frequently and have that one special drink maybe as a snack, instead of primarily having that special drink with every meal, and then maybe we'll drink a little bit of water before we go to bed or wake up in the morning.
For sure. I try to work on that too. So,
Me too.
It's daily.
It's a struggle.
It is.
Well,
Cokes are good and all that, but in terms of your health, they're not. And so,
no.
Yeah,
no, they're just bad for us overall. Well, if we can solve the hydration issue, then it is going to lead to more frequent trips to the bathroom probably, but that's okay, because if we can keep moving, you have a better chance of it not being such a struggle to make it to the bathroom. So I know that you had shared a clip with me that I found absolutely fascinating about just muscle density with someone that is an athlete at 40 and then at 70, and what that looked like versus someone that has a sedentary lifestyle.
Right.
So would you talk about that photo for a little bit?
Yeah, absolutely. I sent you that image, and it's really eye-opening. I can talk about it, give you explanations, describe all that, talk to my patients too, but images are obviously what we see, and we can take that into account a lot more than just words. But there's a true story, but it goes back to something I also told you, that I told you the practice makes perfect. And so when I was younger, I think I was probably working on my golf swing or something, but 13, just getting into it. And my dad told me this, and so I was out there, digging a trench. And I'm like, Dad, I'm practicing. I'm gonna get it perfect. And he's like, no, practice doesn't make perfect. It makes permanent. And so at the time I was like, okay, whatever, Dad. I mean, fine. Let me keep swinging. But since then, and just with life, and just as I got busier, I mean, it's true. Perfect is difficult to reach, but permanent is your state. And so those, we're all creatures of habit. And so what we do on a consistent basis is where our state is. And so if you practice good habits, then you're going to be better than you were the day before, the year before. If you consistently practice bad habits, then obviously things go downhill. And so that image shows a triathlete it's a cross-sectional MRI of the thigh, of the quadriceps. And there it is. And so it shows at the top it's a 40-year-old triathlete, and then in the middle it's a 74-year-old sedentary man, and then at the bottom it's a 70-year-old triathlete. And I'm not saying be triathletes, that's tough, but you can see between the 40-year-old and the 70-year-old that it's almost identical. I mean, he's been able to maintain a fairly good muscle mass, whereas in the middle, just years of a sedentary lifestyle that muscle mass has atrophied, it's shrunken, it's almost just, it's that dark in the center of the image, and the surrounding is all adipose or fat tissue. And if you take that image and just think about functionally, that person in the middle is going to have a hard time standing up from sitting, getting out of bed, getting to the bathroom. They're going to have a hard time doing that. If you also picture a bicycle, you're moving and you need that kinetic energy to stay up, and it's pretty easy to do that. The same with our walking. If we walk, we have to have a certain gait speed. That gait speed alone is a predictor of fall risk over time as we get older. And so somebody that cannot walk faster, then that's going to be a higher risk, because that moment of inertia, that kinetic energy to stay forward, the balance is going to be a little bit more impaired. That once things slow down, you don't have the muscle mass, the muscle energy to be able to move very quickly, then your fall risk goes up. And I see falls all the time. So not only getting out of bed, but just standing and just tripping or turning direction, you can fall. And if that leads to a hip fracture or another injury, I mean, the mortality rates just go sky high after that at that point. So the habits that you do over time, the mobility, staying moving, is important, and nobody's going to get to that overnight. I mean, it takes years, as you saw, 30
Absolutely.
years worth of different habits and choices that somebody makes every day. And again, back in my 20s, I used to work out a lot. I never understood why people don't. Now I get it. And so it's not work out every day, do all this, but do the best you can. Each day try to do something to stay mobile, to try to eat right, make some good choices, and then over time that adds up.
Yeah, it really does. I'm glad you brought up fall risk too. Of course, that along with urinary tract infections, falls
Huge.
are a major move into coming into assisted living or memory care communities. And so when you had that photo up, what was interesting to me is when you have that good dense muscle tissue that's surrounding the bone. So when you do have falls, not to say you won't have injury, but your probability of having a significant break is going to be reduced when you have good muscle mass, as opposed to only having that fat tissue, that adipose tissue, because you don't have the same protection. So it also, the muscle helps with strength and not falling in the first place, but
Right.
not quite as the cushion.
Yeah, in terms of cushioning, I don't know so much of that, but more so you're going to be able to control a fall a little bit more if you have the muscle, or even prevent a fall, really. But as we get older too, our bone mineral densities decrease, and so if I were to fall, I'd probably be okay. I've fallen off a bike and been fine, and cycling and everything, and so fortunately I haven't had any major breaks. But as we get older, the chance of that, it goes up, and so mobility is impaired. But then if you were to fall, the bones can't withstand that kind of impact, regardless of what's around it per se. But if you do have the muscle mass, and also balance is important too, but you might be able to fall a little bit better and not land quite on that that hip bone or your head or shoulder, and so you might be able to protect yourself a little bit better if you lose balance, or again prevent a fall. And so that's kind of the more the goal is to work on that balance, that strength. And again, it doesn't take a lot, it just takes mobility. And if you picture any kind of a car door or any kind of machinery, that if you don't move, or that doesn't move, then it gets rusty, and then it gets creaky, and then it doesn't move more, and it just kind of locks up.
Yeah.
And our joints are the same way. And so we get into this this pattern that I see, as we get older, arthritis kicks in, we have aches and pains, and so something hurts, and then you don't move, and then it hurts more because you're going to try to move, and then you don't move more, and it's just this spiral downhill that just the protection of your pain makes one not want to move. And then that's kind of the worst thing you can do, that you almost want to break through that a little bit, stay active, and try to keep the joints lubricated as much as possible.
Yeah. And fall risk reduction is very important to us at Sage Oak as well. We actually have our community's kind of master plan to circumvent some of that as much as possible by eliminating long hallways. But in a lot of places you have resident apartments, and there's long hallways that they have to go down, not a lot of natural lighting. So we designed our communities to have short hallways that all come to the center of the house, where all the activity happens, where the chef's cooking all that great food
Yeah.
that you smell when you come over.
Pretty good.
That's where activities are happening with our activities director, and people are having conversations. But we want to encourage people to come out. So we want to encourage movement. We don't want you to sit in your room and have that sedentary lifestyle, but we also want it to be manageable. So by having those shorter hallways, the longest one in the house is about 45 feet, which is great because you don't have to have the benches in the hallways to sit down and rest for some of these people that are walking by. And that's also discouraging. So they sit in their room instead of coming out to the activities. We wanted to create an environment where they wanted to come out and it was safe to do so. Is there any advice you would give as far as exercises that may be reasonable? Because a lot of
Sure.
people are going to be discouraged if they think they have to, in their 70s, 80s,
Yeah.
90s, go to the gym every day to maintain that. What are some easy things that they can do at home or in a community such as Sage Oak?
Yeah, it doesn't have to be complicated at all. So the easiest is walking. Just try to walk 30 minutes 3 times a week. If you can do more, great. If somebody has access to a pool, aquatic therapy is also very good. You add some resistance there. If you fall in water, you're gonna be okay within reason. You still have to be safe. I mean, people can still get hurt in water, but the added resistance of that is helping. And it's not so much swimming, but just walking in the waist deep, doing some water aerobics. That would be good. Again, that may be a little bit harder to get to a pool, but if somebody has access, that's good. But light weights, 5 pounds, or you do 20 reps of that, that's a pretty good amount of resistance. And so just some light weight activity to kind of maintain that muscle mass, just some walking to kind of make the cardiovascular, the leg strength, and then just really spine health too is important. And so if I see anything, we can get around some knee pain, hip pain. Sometimes there's replacements that can be done, but those are easier to manage. If somebody's spine is affected over time, whether they lift improperly or just they don't take care of themselves, extra weight, forces on the spine, that's a tougher one to kind of get around. And so once you get into that, the mobility kind of goes downhill is what I see. So taking care of your back is probably one of the biggest things that I recommend too.
Yeah, that's something that kind of gets lost in the mix sometimes. So that's excellent advice for people to remember, that core strength, taking care of your back. Super important. You don't want to have to go through those back surgeries if you can avoid it.
Yeah, and sometimes you can't, but
Yeah.
as much as possible, just to try to get proper mechanics, try to get some help with proper lifting techniques and just bending and all that. But flexibility as well is important. Stretching, some light activity, stretching, balance. Yoga is pretty good if you do it within reason as well. That it also works on your vestibular system, just getting your head in different positions. And so by doing that, it can kind of work with your balance system, and you can do that in a controlled environment. So not everybody can do yoga as
we
you
have
would think,
chair
but
yoga
chair
as well.
yoga,
If
or
you're
even-
limited, then yoga meets you where you are, kind of
Absolutely.
like we do with our cognitive impairment. We like to meet our residents where
Right.
they are. We do that with chair yoga as well.
That's fantastic, and I think that's key. I think it's just modification. So whatever activity level anyone is at, modify what activities they try to do to try to maintain that, but just to keep it within safety reasons too.
Awesome. Well, Dr. A, thank you very
Sure.
much for coming on and giving us such excellent advice and information. You've been a wealth of knowledge.
Thank you.
Practice makes permanent. I think that is the key to take away from this episode for sure. That's great advice to live by. If anyone is interested in reaching out to you, is there an email or website you would like to give people?
Yeah, so primarily I'm at Select Rehab in Denton, and that's where I'm at pretty much Monday through Friday, sometimes on the weekend as well, usually at least one day. But the main number there is 940-297-6500, and they can patch it to where I'm at, or at least give me a message if anybody does want to reach out to me.
Perfect. And if any families or friends are looking for senior care for someone needing assisted living or memory care, or maybe you don't know what you need just yet, please reach out to us at thesageoakcompanies.com. We have locations in Lake Charles, Louisiana, Denton, Texas, and in Dallas, Texas. If you're not sure, reach out to one of them, and we will be sure to route you to the right one. Thank you again, Dr. A, for
absolutely.
joining us on
Thank you
the
for having
Sage
me.
Oak Show, Senior Care Simplified.
Thanks so much.